Without further ado, I'm going to introduce one of my colleagues from the University of Minnesota, neuro-ophthalmologist, Dr. Colin McClelland, to give a talk on diagnosis of eyelid spasm disorders.
Okay, good morning. I'd like to thank the foundation for inviting me to speak, and thank you to Andy for inviting me to speak. I'm a neuro-ophthalmologist and adult strabismus specialist at the University of Minnesota, and we're going to talk today about the diagnosis of eyelid spasm disorders. I have no disclosures. And today we're going to walk you through a clinical approach to the patient who comes in with eyelid, facial, eye spasm complaints, because this is something we see very commonly. And we're going to go through the individual features, the characteristic features of these facial spastic disorders, showing you representative videos, because really I think this is an exercise in pattern recognition for patients and providers, and it's something that we should look at. When you see a video that's representative of these different facial spastic disorders, I think you'll always remember them moving forward. And then when I present each diagnosis, I'll talk a little bit about whether a workup's indicated and why we might choose to do an additional workup. So the patient comes in, why is my eye spasming, doc? This is something that, the oculoplastic specialist, general ophthalmologist, neuro-ophthalmologist, we all hear this commonly. And you want to ask some important questions. First of all, you want to think about how old the patient is and what was the timing of the onset, because this can help you a lot. Was it sudden onset or was it more gradual? What's the characteristic of the spasm? Is it a fine little twitch, or is it a much more intense spasm? Is it localized to one muscle fascicle, so to speak, or is it more diffuse spasm? What part of the face is involved? This is very important. Is it one half of the face, or is it, say, the mid-face involving both sides? Is it the eyelid only? What about a history of prior facial palsy? Because that can sort of suggest a miswiring or a synkinesis kind of problem. Are the movements partially voluntary? For instance, does the patient feel that they sort of need to do it to relieve some anxiety? That makes us think about ocular tic disorders, and many times there's other ocular tics in those patients. And then are there any associated ocular or visual symptoms? Sometimes people say their eyelids twitching, and what they actually mean is their eyeball is twitching, and they have oscillopsy or jumping vision, or they have nystagmus on examination, is shaking eyes, and that's a whole different sort of diagnosis, and I'll give you one example of that later. So let's start with something that we commonly see. This is a 25-year-old medical student. He comes in studying for final exams. He's really stressed out. He's drinking a lot of caffeine. He's not sleeping well, and he's convinced that when his eyelid started shaking, that he's got some terrible diagnosis that's going to take his life quickly. And I'm going to show you the video here. So if you look really closely at the upper lid, nasally, towards the nose, you'll see a really fine twitching there. Does everyone see that? Okay. Anyone want to shout out what this might be? Blepharospasm. It's in the differential, right? Okay, this is eyelid myokymia. It's not actually blepharospasm. And this is very, very common. It's a high frequency, meaning very frequent, low amplitude twitch of a very small individual muscle within the eyelid. It might be the upper eyelid or the lower eyelid. It's usually unilateral when you're seeing it, but over time it can migrate. What I mean by that is the patient might say, oh, initially it was my right upper lid, and then I started feeling it my left lower lid. And these are again our individual muscle fibers. It's not the entire orbicularis. It's not the entire eyelid. It's just kind of a focal little area, and it's associated with with stress, sleep deprivation, and caffeine. So the workup, there really isn't a workup required in this setting. This is a benign condition. It's not associated with bad things, despite the medical student concern about that. By the way, this happened to me in medical school also, so it's pretty common that we have this happen. The one caveat to this is that if you have mid-facial twitching in association with the eyelid twitching, then we do worry a little bit more about something like multiple sclerosis. It can be an indication of demyelinating disease, right? And so you have to keep in mind the context of how old the patient is there any other neurologic symptoms, but I really look carefully for the mid-facial twitching. If it's isolated eyelid, it's not something that you worry about MS or require a workup, but if you have the mid-face, you do need to think about that. Typically, this is self-limited. You tell the patient, don't worry about it. I joke, you tell the patient to reduce stress, even though that's easier said than done, right? It's always hard to reduce stress. And then, this is generally going to go away on its own, but if it doesn't, you can consider injection of botulinum toxin, and it responds very favorably to that. So more about blepharospasm? This is really the prototype facial spastic disorder, and this is why we're here today. This is generally bilateral, although it's important to keep in mind that in up to 25%, it can be unilateral at onset and then become bilateral. There's a slight female predominance, and the differential diagnosis here is idiopathic isolated blepharospasm without anything else, versus Meige Syndrome, and we'll talk about that. We have blepharospasm plus other dystonia and spasms in the face, and then secondary blepharospasm associated with other neurologic disorders or ocular surface disease such as dry eye. So I'm going to show you an example of mild blepharospasm here. So you'll see this patient, it just looks like a prominent blink. He doesn't have sustained severe contraction of the eyelids. It's just a frequent blink, but you can notice that his brows are up. So he's already he's using his frontalis muscle to try to avoid this process of blinking, but he's still blinking frequently. So I characterize this as mild, and this patient actually wasn't too bothered by it and decided not to proceed with botulinum toxin. I'm going to show you a much more severe case that many of you are going to be familiar with. So this patient has really sustained spasms, and at one point you see it's just so hard to fight. She just keeps her left eye closed, and the right eye doesn't seem quite as involved, so she looks by opening that right eye. And this is really when blepharospasm becomes debilitating. So this is thought to be a progressive degeneration of the basal ganglia, and I'm sure we have a neurologist speaking next who can probably go into more detail about that. But the symptoms generally start around age 55, and then they often start as relatively mild and progress over months to years from, initially being more sort of like a mild blinking to much more sustained and forceful spasms. Up to 90% of individuals have neurosensory tricks. These are things that they can do that sort of help to alleviate the blepharospasm. I'm just curious, if we could get a raise of hands, how many folks have some neurosensory trick that they've identified that helps them? Okay, so I would guess somewhere close to 50% in the crowd. And this is commonly a misdiagnosed disorder. That's right. Woo. Good thing I wasn't doing a research study, or I'd be way off. Okay, so this is commonly misdiagnosed. And in fact, 50% of patients, I'm sure I don't need to tell you guys this, see more than 5 doctors before they get a final diagnosis. And that's something that healthcare professionals, we need to work on. This is not just a cosmetic disorder, this is a functional disorder. So, it affects driving, reading, work. We talked about neurosensory tricks. Other things that help to improve is getting better sleep, trying to reduce stress, and then artificial tears if there happens to be an ocular surface component to the blepharospasm. What about workup? I would say that in my clinic, when I see patients who have what appears to be isolated blepharospasm, and they fit the sort of typical age group for blepharospasm, I do not do any additional workup. When there's concern for an associated neurologic condition, and I'm always finally looking for these features, symptoms or signs of Parkinson's disease, for instance, then I'm going to send that patient on to a neurologist with expertise in movement disorder for more evaluation. But in the absence of those signs and symptoms, on my exam, I don't institute a workup. In terms of reflex blepharospasm, this is when you have eye surface disease that leads to blepharospasm. Sometimes it can be pure reflex blepharospasm, so as soon as you treat the ocular surface disease, the blepharospasm goes away. Sometimes it's a component of the blepharospasm, and you treat the eye surface disease and it gets better. So we have this pathway, the blink pathway, and what happens is you have input, sensory input from the trigeminal nerve that then triggers a compensatory, when stimulated, triggers a compensatory facial nerve blink. And so that pathway can go awry with ocular surface disease, where you have too much stimulation of the trigeminal nerve, and you get, instead of a blink, you get a spasm, right? So this is the mechanism behind reflex blepharospasm, and in many of those patients, when you treat the ocular surface disease, the spasms will get a lot better. Meige syndrome, I tell the residents, is a blepharospasm plus. The plus is lower facial dystonia, cervical dystonia, tongue dystonia. Limb muscles can be affected more rarely, and then very rarely we can have respiratory muscle involvement. Up to 50%, according to the literature, of patients can progress with blepharospasm that seems to be isolated, can progress on to Meige syndrome. Generally, if it's going to occur, it usually occurs within the first 5 years of blepharospasm. So here's a patient. She does a wonderful job. She has mild blepharospasm, but there's something else going on in her case, and she does a really nice job of explaining it. So I'm just going to let her tell us. Make sure we have the sound turned up here, folks. Okay. And I want you to tell me in your own words, what's the problem that has brought you in to see me?
That my eyelids close and I can't get them back open, and they stay closed for quite a few seconds.
Watch your eyebrows.
That's interrupting my driving and walking. Reading, it discouraged me from doing all that. I won't engage in a lot of stuff anymore.
You're not seeing a lot of spasm here. You'll see it just not a lot of spasm, but you see her eyebrows are frequently coming up. She's really trying to get those eyes open. And now, to accentuate this, I'm going to show you what it looks like: repeated eyelid closure and opening. You see her eyes really drive up. She's trying incredibly hard to open her eyes. All right, I'm going to open it up to the audience again. Does anyone know what this is? Apraxia of eyelid opening. Excellent. So this commonly co-occurs with blepharospasm, although it may occur in isolation. It is also associated with Parkinson's disease and progressive supranuclear palsy. So in these patients, especially if they have isolated apraxia of eyelid opening, I ask those questions and do the exam very carefully to see if there's any warning signs that we might be dealing with another associated neurologic disorder. And this is a pathologic inhibition of the levator palpebrae superioris. So if I break that down into non-medical jargon, it's the muscles responsible for opening up the eyelids aren't working properly. So it's not that the eyes are spasming, it's that the eyes don't want to open up. And again, oftentimes there's both of those together, but some patients can have much more mild blepharospasm and very severe apraxia of eyelid opening. I find that these patients are often difficult to treat because it's much easier to stop an overacting muscle, such as the orbicularis, than it is to stimulate an underacting muscle like the levator. That said, I'm sure someone's going to talk later that there are tricks and there are places that you can inject the Botox that would make it more effective for patients who have apraxia of eyelid opening. Okay, here we got another video, and I want you to look very carefully for the location of the facial spasms in this patient. Do you think it's isolated to his mid-face? No, it's not. Is it on the right side of his face or the left side or both? The left. So we see the upper face involved, we see the mid-face involved, and we see the lower face involved. So this is you guys are too good. I should have you come teach the residents. So this is unilateral, high frequency. Associated weakness of the face is relatively common, and it involves the upper, the mid, and the lower face. Distinguishing it from typical blepharospasm, which involves essentially the orbicularis and the eyelids. Obviously, it can involve other parts of the face, but this is unilateral, entire face. So it has a younger age of onset in general than blepharospasm. There is not a female predominance in this disorder, and it's thought to be caused in most cases by neurovascular compression. What I mean is that there's a tortuous blood vessel that's sitting right next to the facial nerve on one side. This is why it's usually unilateral, because fortunately most patients aren't unlucky enough to have two tortuous blood vessels pushing on the seventh nerve, and it's irritating that seventh nerve. We talk about ephaptic transmission, which is a big scientific term that essentially means crosstalk between neurons within the facial nerve. So we have these neurons running in parallel, and something irritates them, and most of the time it's compression by a blood vessel, and then you get crosstalk between the parallel neurons, and I describe it to patients as it's sort of like short-circuiting of the facial nerve. It short-circuits and it's spasming and firing. The nerve is firing when it's not supposed to. Most of the time, again, it's neurovascular compression. Most of the time, these patients are treated with botulinum toxin. If it's really severe, neurosurgery can come in and put a sponge in between the abnormal blood vessel and the nerve. And there are other secondary causes besides neurovascular compression in 1% or less. So for that reason, I do get an MRI in these patients because there is a chance that there could be something else like a tumor or demyelination in effect here. Okay, we've got another patient here, and I'll tell you his history is that, he had Bell's palsy a few years ago, which is an idiopathic viral infection that leads to facial nerve palsy, and in many patients it resolves. In some patients you get incomplete resolution of the facial nerve, and he says ever since then his face does funny stuff.
Now I want you to blink. Good. Do it again.
What do you notice when he blinks?
Good.
His face
All right.
twitches. That's correct.
And again, blink. And smile real big for me. Good. I want you to raise your eyebrows. Raise your eyebrows.
What do you notice when he tries to raise his eyebrows?
Very good.
Right, so we have a couple things going on. He has incomplete resolution of the Bell's palsy, so he has facial weakness on that left side. And he also has synkinesis, or miswiring. As that damaged nerve healed itself, some of the fibers that were supposed to go to the brow got rewired and they went to the midface. So when he tries to lift the brow, the midface twitches and spasms. Right? So this is facial nerve synkinesis. It's usually unilateral for the same reason that most folks are not unlucky enough to have bilateral facial nerve damage. Facial weakness is very common, as we talked about, and the etiology is essentially anything that damages the facial nerve can lead to this aberrant regeneration, or as the nerve regenerates itself, it kind of grows back in abnormal ways. If there's a history of Bell's palsy, then I do not institute a workup in this setting. Okay? If, however, the patient comes in, has no history of Bell's palsy, and just seems to have a progressive facial weakness demonstrating synkinesis, then you can't exclude the possibility of some sort of compressive mass slowly growing and pushing on that nerve. So for that reason, in those patients, I get an MRI. And we're going to end with the fun mimicker. So this patient comes in, says my eye's twitching. She doesn't specify what, but the assumption is generally that we're talking about the eyelid twitching or the facial muscles twitching. But then when you examine her really carefully, you notice something very interesting. So here's her right eye. Here's her left eye. Look at the blood vessels on the conjunctiva, over the white part of the eye. You see this? The whole eye is doing this. Anyone have any idea what this is? I don't expect you to know because I'm not supposed to be presenting this at the conference, right? This is not a facial twitch disorder or facial spasm disorder. But sometimes patients come in and they think they have something and they have something else. This is superior oblique myokymia, not eyelid myokymia, superior oblique myokymia. This is almost always unilateral. This is another disorder of neurovascular compression. So there's an abnormal blood vessel pushing on the trochlear nerve, which supplies the superior oblique muscle, whose function is, and there's one on each side, to depress the eye and to encyclotort the eye. So if you have abnormal spasms of that muscle, you're going to have these torsional movements of the eyeball and also a vertical jumping. And sometimes the torsional movements are more prominent than the vertical jumping. So these patients say, many of them say, my vision is jumping. But sometimes they have a hard time describing that, and they'll just say, my eyes twitching, right? The workup in this case is an MRI. Most of the time it's normal. If it does show something, it usually shows an abnormal blood vessel pushing on that trochlear nerve. And generally, this is something we would treat medically as opposed to surgically. So, in conclusion, spastic disorders are commonly misdiagnosed. It's something that the healthcare world needs to improve on. And I'm really grateful that we're here with you today because I think we can all improve awareness of these different disorders, which would lead hopefully to earlier diagnosis and treatment and less anxiety for our patients. We can do better than 50% of patients seeing more than 5 providers. Thank you.